other panel members to come up, please.
Sammy.
We have Saro, Khemichian, and Mitra, Nadim, both from USC, as USC is overrepresented again. And Sammy Saab. Where are you, Sammy? What's the name of that place?
Visiting professor.
Visiting professor, American Airlines professor of medicine at UCLA. And you heard our two speakers today. So we're going to have questions, and we'll start with Vinay.
Thank you. This is a quick question for Dr. Kowdley. In the final abstract that you presented about surveillance for cholangiocarcinoma, I know the cumulative incidence was rather low, but I was wondering, did that study look at CA19-9 and whether that improved the detection, early detection of cholangiocarcinoma?
Do you want to repeat the question, Kris?
So the question was, did they include CA19-9, and did that change detection? So I'm not aware that CA19-9 was part of the protocol. Imaging was done in all the patients. CA19-9 was done sort of ad hoc, to my knowledge. But it's an excellent question as to whether that would have increased the diagnostic utility, although the very low prevalence overall, given that it was as low as 2%, would suggest that it probably would not have, because you didn't have a lot of false positives.
Nora?
So I have two questions. First, Kris, the HDT trial. So how do we know this? I mean, you sort of made the point that when they compared it to URSO, it didn't really look that different. So my question is, really, is this any different from URSO? And since short-term URSO has some effects, but we know long-term may not be there, I'm just wondering what this really adds in terms of our sort of step forward for PSC. We're very desperate for therapies, but I'm just wondering about, really, is this different than URSO?
It's not clear, quite frankly. I mean, it is a salt as opposed to an acid. Berberine has, a lot of very interesting properties that appear to have anti-inflammatory and anti-fibrotic, downstream effects. If you look at the magnitude of the reduction in the alkaline phosphatase, it does appear to be greater in the short term. It is generally safe and well tolerated, except for the GI symptoms that I mentioned, which are, I think, tolerable. So the short answer is it's really unclear. And the way the phase 2 study was designed, was somewhat challenging, because we had patients who were not on URSO and patients who were on URSO, and so they had to stop the URSO, and then they were initially entered in the study, but of course then there were patients who rebounded, and so if they then respond, you don't really know whether the response is simply because of reintroducing an URSO compound, or it has something above and beyond just URSO alone. So you have hit the nail on the head in that, as to whether this represents a meaningful additional therapy above and beyond URSO alone is not clear, but it is sufficiently interesting given the additive properties of berberine, and given that this is a new compound, this is neither URSO nor berberine, and given, as you say, the complete lack of available therapies and the relative safety so far, it seems reasonable to at least move it forward. But whether the effect, we do not have data that I'm aware of that shows us the effect of ursoberberine is different than URSO alone, because that would require sort of a 3-arm trial with longer follow-up.
Why didn't they design a trial that way? Why did they use placebo instead of an URSO arm?
Well, I think because, first of all, the use of URSO is kind of highly variable. and evolving as we get more and less data coming out with regard to dosing and safety of URSO. But this was designed as a proof of concept, and the goal was really to look at the efficacy of ursoberberin or 1801 compared to placebo, not necessarily compared to URSO.
If I could ask a second question. So it's around hepatorenal syndrome. So I think I'm very impressed with the epinephrine data. But yet I sort of know, at least in our practice, we don't go to that very often. And maybe I'll be interested to hear, across centers here in Southern California, whether others are being much more kind of engaged in using epinephrine as a therapy. So maybe, Florence, you could just sort of speak to that. And Mitra, maybe also get your comment about that. Like, it seems like it's so much better than sort of octreotide midodrine. Why are we going there? We should just maybe go straight to epinephrine. And especially this data that now says maybe we could use it in maybe a step-down setting. So just wanted some comment on that.
Okay, Ray Kim, first of all, was extremely brave, and he had the negotiating skills with his nursing administrators to get them to allow him to use it outside ICU. Right. He's the only person I know who has done it outside ICU. The reason why it's not commonly used is because there is a lot of resistance of having these patients in ICU just for norepinephrine. Yeah. I've used it in ICU and it's worked well.
Mitra, do you want to maybe comment?
So regarding, again, Ray Kim's study, just as Florence mentioned, it really wasn't a step down. It was really closer to an ICU. They had every 15-minute nursing, monitoring of patients. Even in a step-down unit, they don't do it every 15 minutes. The ratio was not the typical 4-to-1, which is a step-down. They made it 3-to-1. And even that, they had 25% arrhythmias. And so I would be shocked if, this flies in, because it really, again, wasn't a even true step down. And their step down was really, really liver specific. So it wasn't just any step down. Why we don't move patients to the ICU? Well, you've seen at least KEC. We can't, to bring a patient just for norepi, just for hepatorenal, it's not going to fly in most ICUs because they're full. And then it begs the question, the underlying problem is really the liver. And in, the LA area, you bring someone's MELD from 40 to 39, you still haven't fixed the problem, which is the liver, and ultimately the patient will end up dying. So, the treatment for HRS, if you go to Ochsner, is going to be very different from treating, hepatorenal in the LA area, where ultimately the patient's going to die with a good creatinine because the liver is still kind of not good. I think in patients there are certain patients, but again, if they're in the ICU, most of them are usually, as you've seen, they're already on norepi, because the reason they ended up in the ICU was because they're hypotensive, septic, they're already kind of on that, cocktail, you can say, yeah. But moving a floor patient to the ICU in most ICUs in the nation, I think it would get blocked because there's just no space in the ICUs, and it's not viewed as, okay, because if they're on the floor, they're like, well, they look good. I mean, that's always the comment, oh, they look good, even though kind of the liver's failing, the kidney's failing. So you really have to have another indication to get your way up to the ICUs in most centers in the nation.
Sammy, what are you guys doing at UCLA?
So we're not using norepi. We don't move people to the ICU to put on norepi. If people are already in the ICU, they're also not being treated with norepi for hepatorenal syndrome. I mean, by the time we get to these patients, they're usually pretty late in the game. They have high MELD scores, high serum creatinine. And like she said, these people already, have very high MELD score. And, and no studies have shown a difference in survival. Whether it be terlipressin, whether it be norepinephrine, nothing has. And so why, part of us thinks, why would you want to artificially lower someone's MELD score and, and impact their chance of getting transplanted soon? So, and there's a great editorial by Bob Brown in liver transplantation, arguing that if we do this artificially, then maybe we should be getting MELD exceptions or lock their MELD scores before we use telepressin or use norepinephrine.
I think in, oh, go
yeah.
ahead.
It's just that the philosophy up north is slightly different from the philosophy down here. And I think, Nora, you've worked in both. And you know, we will not hesitate to send a patient into ICU to try the norepinephrine. And if the MELD score comes down, then you give the patient a little bit more time to wait for the organ availability. And there is data to show that if you respond, you do improve your survival. And for these reasons, we will try to move the patient into ICU. But I can't speak for the centers in the US.
I think, again, it all comes down to organ allocation. Again, when Ochsner can, transplant a MELD, 22 within a week, and, the LA MELD 40 blood type O has to wait 4 weeks minimum, bringing that 40 even down to 39, can be, at the end, as Sammy said, there's no difference in survival outcomes. So you're basically, by doing that, you can actually cost the patient's life. So I think there, in Europe, I think Perret and Paolo also wrote a nice editorial. This was a couple of years ago. I think they're doing it even in Italy. They're considering amongst themselves that if you are refractory to treatment with terlipressin, that every time you stop it, it comes back, and they capture that either highest MELD or they give them points like dialysis, and that way, that's a different scenario than just saying, okay, you're going to artificially, or you're going to bring the creatinine down, but on the long run, in certain regions, again, I'm not saying all regions, you're going to actually cause more problems for that patient than really the benefit of giving them norepinephrine.
I mean, there are some gains, there are some data suggests that if you do intervene early, and the patient does get transplant, you might prevent the need for dialysis post-transplant, or a need for kidney transplant after liver transplantation. But in Los Angeles, it's a whole different beast.
Well, also that we have a lot of patients where, let's face it, we're trying to decide. You got somebody on the floor whose creatinine's rising. You're trying to decide if it's AKI or HRS. We use Minidrin octreotide albumin, which sucks. It has very little data. The rest of the world uses telepressin. So, and though not all those people are going to end up being transplanted, at least at our center. So, Florence, are we going to get this drug in the United States? And if we do, is it going to be black boxed or not for fluid overload, which was obviously from the
Okay, I'm
albumin?
speaking out of context.
How are we going to give it?
But I believe that it's coming in
Okay, good.
about 2 months.
All right. And is it going to be continuous infusion? So we, or are we going to have to go in?
No, you have to go and do the study again with continuous infusion.
So the GI fellow's going to have to go in and give telepressin infusion injections. That'll reduce the number of applicants, Nora. That'll really help.
I suspect in the US it's going to start in the ICUs.
Yeah.
I would be.
So that was my next
I would
question:
be
is everybody going to have to go to the
surprised
unit?
if it- I doubt it would be on the floor. People are going to get, not people, but hospitals may be nervous about step down initially. So until there's better data, my gut feeling is, at least in the US, most centers, if they're going to give it, will be giving it in the ICU setting, at least for the first couple of days, to make sure the patient's stable before they move them down to step down.
And given in a context.
Yeah.
So there are some concerns about how MELDers getting this medication, people high serum creatinine levels getting this medication, people high ACOF scores getting this medication. So they'll be given a context. What we don't want to see is, people using it like cowboys. And because there are risks involved with terlipressin.
Yeah.
Respiratory failure.
So-
It's a risk benefit, and you
Florence-
gotta properly select your patients.
Pharmacy will probably block it from the cost perspective.
Well, I was going to
I
ask
think there
next.
will be black box.
Florence, what will be will the prescribing recommendations be Q6 hourly, and will it be more at maximum of 14 days, just like it's the rest of the world?
I can only speak in terms of the confirmed study. However it's going to be labeled, I am not privy to that information. But it's likely that they will not allow people with high creatinine, people with ACLF grade 3 to use terlipressin. And they may also limit the amount of albumin to be given terlipressin.
Thank
The
you.
problem we have, we can't measure fluid status very accurately on the floor. We cannot at all.
Right.
So that begs.
So you
the question
think
about
most
albumin use.
people are going to end up with central line in the ICU?
Oh, I think so. I think at least initially.
Again, I think pharmacy will, angiotensin II, which was a drug that came out for, pressors, our institution has it. We've had it for the past year and a half, but we're not allowed to really write it. It started off first only in the operating room, and now only certain teams can write it if necessary, if allowed by pharmacy in the ICUs. Because of the cost, it's about $3,000 to $5,000 a day. So
This is for angiotensin.
This is for
Not
Ang too.
With telepressin.
So I think terlipressin will be in a lot of centers is going to be kind of,
I see.
pharmacy will probably have a lot of control depending on what the cost of the medication is, who's going to get it, how long are you going to give it, what's going to be your endpoint, and not allowed to be, as Sammy said, just give it to everyone, because cost is going to be an issue. Pharmacy is mainly concerned about the cost.
And one more thing, Florence probably knows more than I do about this, but there are studies going on right now looking at continuous terlipressin for fracture ascites in the U.S.
Well,
That's correct, that's another drug company, but
if it's
I'm,
expensive, that's
yeah.
a tough sell.
I'm ever so glad I'm living in Canada where you just write it, government pays for it.
Question. Front or back microphone, yes, please.
Hi, Calvin Nguyen from Kaiser OC. This question for the whole panel, but mostly for Dr. Kowdley. So it seems that the data actually suggesting to stay away from, for OCA, to stay away from cirrhotic patient with decompensation. But if you already have a patient already on URSO and OCA, ANGS is working, alphos is low, but they admitted to the hospital for the first episode of decompensation, would you just stop the drug permanently, or it's just if they get over that episode, would you restart the medication knowing it's actually working for the patient?
So, and the reason they got into the hospital is because of a decompensated episode?
Correct, first episode.
Can you repeat the question, Kris?
Yeah. So I think the question was, a patient is on OCA, known to have cirrhosis, and doing well, but then has a decompensation event, and admitted to the hospital, then would you permanently discontinue the OCA, or what would you do? How would you handle that? So I think that at the present time, it would be unwise to continue OCA in a patient that's decompensated, whether it's temporarily or not. In fact, if you look at the label, and if you look at the main concern that the FDA had, it was about patients who had a decompensation event in the past or current evidence of portal hypertension, such as varices or platelets less than 120,000. So for a patient that appeared to be doing well and then decompensates, I think two things have happened. One, you've reached therapeutic futility because our goal is to really reduce decompensation. That was not prevented. And then the second is that patient, by having that decompensation event, is now in a different category. Even if they recompensate back, they're not the same patient. So I would discontinue and not restart.
Thank you.
I agree also. No, sorry, go ahead.
So Kris, so your patients with presumed cirrhosis, do you do anything special before starting obeticholic acid? Like do endoscopy, check for a big spleen, check the platelet count?
Yeah, so there's a large data set that was used to generate an algorithm that was presented at EASL. And the simple, easy way is essentially if a patient has cirrhosis, exclude the presence of significant, trace varices. I think, we all struggle with that. Is it really there or not? But when it's unequivocal varices, thrombocytopenia with platelets less than 120,000, or if they're Child-Pugh A6 versus A5, those are patients that should not, in my opinion, be treated with OCA.
Thank you. Question.
Hi, this is Niyun from USC. I have two questions. One is regarding PBC trial. I know PBC trial, you're not doing liver biopsy to check, right? And we were talking yesterday about this overlapping, NASH, NAFLD with other liver disease. And the new treatment for PBC actually a lot of medication come from NAFO, NASH, and obeticholic acid. You talk about PPAR, you talk about berberine. And do you think, the treatment, efficacy come from the treatment of NASH, underlying NAFLD? Or should we change the trial design in the future? The patient should have liver biopsy to diagnose, confirm there's no overlap of NASH, just PBC.
Yeah, excellent question. So to summarize the
Repeat
question,
yeah.
it was many of the drugs currently being used to treat PBC have also been tried in NASH. And could it be that some of the reason for the efficacy in PBC that we're seeing, at least indirectly, be related to the fact that it's working against the underlying NASH, which may be common in these patients? And therefore, should we consider using liver biopsies as additional data points in future clinical trials? Is that what you, yeah?
Yes.
So,
yeah.
so first of all, a very interesting thing happened with seladelpar that some of you may know. There was a phase 3 trial that was already underway called the ENHANCE trial using the composite endpoint and was fully enrolled and in fact was in about 3 to 6 months of follow-up. At around the same time, a concerning finding was reported in the seladelpar NASH trial where a review of pathology in the NASH phase 2 trial was stated to show some concerns regarding interface hepatitis and some vascular changes and portal inflammation in NASH that were suggested as being possibly drug-related. So the study was stopped. All development with seladelpar was stopped, and an independent panel was brought together that looked at all of the biopsies and reported everything pre and post. And the ultimate conclusion was that, in fact, the findings that were reported as concerning findings were present at baseline. There were no new findings. And remember, in the trial that was going on, there were no biochemical signals. And in the PBC patients, they were appearing to respond exactly like in the phase 2 trial. So after all of this went through and discussions back and forth with the FDA and so forth, it was decided that that was a red herring and it was not actually a real thing. It was simply, a chance finding. And so all of the seladelpar program in PBC has resumed with both an open label extension of the previous phase 3 as well as a new phase 3 trial. But as a result of all of this, it has now changed the approach to both phase 3 trials that are ongoing. So the elafibranor phase 3 trial and the CIMA-BAY phase 3 trial with seladelpar are both incorporating liver biopsies. They're not required, because obviously it's not required for diagnosis, but strongly recommended. And it'll be very interesting because it'll address your question as how many of these patients also have underlying NASH, and if they improve, is it because the NASH resolves or the PBC gets better?
Right.
Mitra, you want to comment whether or not you think these patients, I never considered whether PBC patients also had NASH, and we're not biopsying anybody with a positive antimitochondrial antibody, so you're going to start looking for that?
Well, I mean, certainly it is true that with URSO, substantial number of patients will gain weight. Those of you that treat a lot of PBC patients know this. And those of us that have fiber scans see that many of our PBC patients have not only increased stiffness, but also increased CAP scores. Having said that, so far in the patients that we've started to biopsy now because of these trials, we're not seeing much in the way of NASH. We're seeing some fatty liver, but not florid NASH.
We definitely, in NAFO NASH patient, they have MA positive, and they could have predominant alkaline phosphatase elevation. So we did biopsy. The patient did not have PBC, but have NASH. I mean, having MA positive or NA positive is also very, not uncommon in the patient with NASH, NAFO.
But the liver panel is very different, right? PBC is a cholestatic liver injury. Fatty liver is more parenchymal. So, I mean, I think that will give you a clue. Saro, what do you guys do? What's your practice?
I mean, in general, outside of clinical trials, yeah, sometimes it's very easy to tell two patients apart from each other, but yeah, sometimes it is very difficult.
Do you do fiber scans or do biopsies?
Yeah, fiber scans, biopsies rarely, again,
Okay.
because most of the time patients also are somewhat hesitant about that, but we use fiber scan a lot.
Okay.
Yeah.
And that's a good point, Carl, whether patients gain weight on or so, which they do, and then their alk phosphorus it goes up. What is it? Yeah, Kris.
Yeah, so just a couple of things to your point. First of all, the AMA, I don't know how many of you are seeing this now, but the AMA used to be an immunofixation study, and we used to get a higher quality result in terms of titers. And now it's an inexpensive ELISA test, and you just get a number. And if it's greater than 20 or 22, it's reported as positive. The vast majority of those patients, when you do a confirmatory test, do not have a positive AMA. So before you interpret a positive AMA as being positive, it really is, to me, only positive when it's, at least above 35 or 50 or 60. The true PBC patients, their AMAs are not 21 or 22 or 23, kind of just above the upper limit of normal. So that's number one. So if you see an AMA that's positive at that low level with that ELISA test, that doesn't mean it's PBC. Even if the patient has an elevated alkaline phosphatase, you want to do another confirmatory test. The second point with regard to the prevalence of a positive AMA in patients with NASH, so we actually published a paper on this with about 600 patients from the NASH CRN, and AMA positivity, true AMA positivity, not this false positivity, is extremely rare in NASH in the absence of true concomitant PBC. But ANA positivity is not infrequent. About 10 to 12% of patients who have NASH will have positive ANAs, and they're generally low to moderate titer. And interestingly, histologically, we find those patients have more portal inflammation than you typically see with NASH. It's not clear whether it's some variant of low-grade autoimmune hepatitis or something else, but it doesn't appear to be true overlap. So the vast majority of these patients have NASH. The ANA kind of muddies the water. They do have some slightly different histologic findings, but AMA positivity and true overlap with NASH and PBC is actually quite uncommon.
But I think your point's well taken about concomitant conditions, and I just want to highlight, ask about alcohol too. Right now during Zoom, COVID, our autoimmune hepatitis are all coming with high liver enzymes from drinking, drinking at home.
One last question, Jeff.
Yeah, sorry.
Yeah, just a question about terlipressin and epinephrine. In patients who get transplanted who have poor kidney function after transplant, would there perhaps be a role for terlipressin early post-transplant if some of the physiology or pathophysiology that's going on with the patients hasn't really changed yet, because it could take, as you mentioned, several weeks before you see improvements in the sort of hyperdynamic state and other things. So I'm wondering about terlipressin early post-transplant.
God, I have not seen any studies. I don't know. Have you guys seen studies?
No, there has been no study using terlipressin in the post-transplant setting. However, it is true that the abnormal hemodynamics can take weeks to months to correct. So theoretically, there is a role, but no one has done that study.
I'm sure anybody's brave.
Good study.
Good question.
There was one study, there's definitely but there was one study, I think, intra-op, and I can't remember who did that. They give like a dose of terlipressin intra-op or something. But again, but there is definite, even for, pre-transplant, for those who do respond, Paolo just recently published that their, long-term CKD was less post-transplant. So there is benefits. Again, it just comes down to whether either organ allocation can be different in the U.S. or UNOS can kind of consider, terlipressin use or recovery or something as kind of like a dialysis or something, giving points. But there definitely is some, study recently showing the CKD is less.
Well, you don't really need terlipressin. If you can correct it with middle octreotide, the chance of developing CKD, it's also lower. I mean, right now we're all talking theoretically because we still don't have telepresence yet.
But soon, right, Florence?
Soon, yes.
Soon.
We're going to take a 25-minute break.
Agrees.